Bismillah ar-Rahman ar-Rahim. Welcome to our cardiology department. My name is Dr. Adham Abdel Tawab. I'm a lecturer of cardiology. I'll be talking today about systemic hypertension. By the end of this lecture, you should be able to define hypertension, differentiate between the different stages of hypertension, differentiate between primary and secondary hypertension, recognize cardiovascular risk factors and how to risk stratify a hypertensive patient, recognize rationale of management of patients with hypertension and recommended goals, describe classes of antihypertensives and their indications for use, feel confident recommending lifestyle modifications to patients, differentiate between hypertensive emergency and urgency, define resistant hypertension and its proper management. You should acquire the skill to measure blood pressure properly and to diagnose hypertension, and gain the attitude and behavior of motivating the patient on lifestyle modification and maintaining long-term compliance. Let's start by the definition and classifications. Hypertension is an increased or hypertension within a closed space. It may be arterial, like systemic hypertension, our topic today, or pulmonary hypertension. Can be venous, like systemic venous hypertension, pulmonary venous hypertension, or portal hypertension, and intracranial hypertension. Systemic hypertension, systemic arterial hypertension, is a chronic medical condition in which blood pressure is elevated more than or equal to 140/90. It can be differentiated into two main types according to etiology: essential or primary hypertension and secondary hypertension. You need to check the regulation of blood pressure in your prior studied subjects. Primary or essential hypertension is by definition of unknown cause. It represents more than 95% of cases of hypertensive patients. Risk factors for primary hypertension occurrence include obesity, inactivity, alcohol abuse, smoking, low potassium, calcium, magnesium diet, increased salt, sodium diet, stress, and genetics. Risk factors for hypertension can be also classified into modifiable or changeable risk factors and unchangeable or unmodifiable risk factors. The modifiable risk factors include obesity, increased salt usage, alcohol abuse, smoking, stress, and sedentary lifestyle. Unmodifiable or unchangeable hypertension risk factors include race, black race, aging, positive family history or genetic factor, gestational hypertension, and gender. Secondary hypertension represents only 5% of cases of hypertensive patients, is high blood pressure caused by another medical condition or medication. It can be classified into many types, like renal hypertension with chronic kidney disease, with renal artery stenosis, with like renovascular hypertension, endocrinal hypertension like with pheochromocytoma, Cushing syndrome, Conn's syndrome, and acromegaly, in females with preeclampsia, with some drugs like oral contraceptive pills, migraine drugs, some cold medications, and non-steroidal anti-inflammatory drugs, with some other conditions like aortic coarctation. A mnemonic for some secondary causes of hypertension is CHAPS. C for Cushing syndrome, H for hyperaldosteronism, also known as Conn's syndrome, A for aortic coarctation, P for pheochromocytoma, S for renal artery stenosis. Getting to the diagnosis of systemic hypertension, as usual, it's made in the usual steps by history, proper physical examination, including general and local examination, which searches for target organ damage and established cardiovascular diseases and risk factors, and measuring blood pressure. Diagnosis of hypertension is mainly based on persistently elevated arterial blood pressure. Regarding signs and symptoms of hypertension, many people are unaware that they have hypertension, and in many cases it's accidentally discovered by its complications or by incidental measurement of blood pressure. That's why systemic hypertension is sometimes called the silent killer. Non-specific symptoms or mild symptoms might sometimes occur in the form of vague symptoms like headache, like morning headaches, tinnitus, ringing in the ears, dizziness, some confusion, fatigue, some shortness of breath, changes in vision or sometimes up to blindness, nausea, anxiety or easy anger, nosebleeds, palpitations, flushed or pale skin, and chest pain. Examination: blood pressure should be properly measured and assessed. This will be fully covered in the clinical session. According to measurement of blood pressure, grading of hypertension can be done. Optimal blood pressure is less than 120 over 80. Normal arterial blood pressure is a systolic of 120 till 129 and diastolic 80 till 84 mm mercuries. High normal is 130 to 139, 85 to 89. Then starting with the abnormality, grade 1 hypertension from 140 to 159 mm mercury and diastolic 90 to 99 mm mercury. Grade 2 hypertension from 160 to 179 mm mercury and diastolic from 100 to 109 mm mercury. Grade 3 hypertension is more than or equal 180 mm mercury and isolated or diastolic blood pressure more than or equal 110 mm mercury. Isolated systolic hypertension is the presence of normal diastolic blood pressure less than 90 mm mercury and systolic blood pressure more than or equal 140 mm mercury. Some other hemodynamic subtypes of hypertension. Diastolic hypertension sometimes occurs in middle age with it's a classical essential hypertension. It occurs more in males. Isolated systolic hypertension occurs sometimes in elderly, more commonly in females, with aortic stiffness, rapid reflection of waves from the periphery, and augmented systolic blood pressure. Investigations for hypertension search for cardiovascular risk factors, target organ damage, meaning complications of hypertension, and established cardiovascular disease. They can be classified into investigations for all cases, like routine labs for diabetes mellitus, lipid profile, and ECG, and some investigations are used for selected cases only, like ambulatory blood pressure monitoring, echocardiography, and some sophisticated investigations for secondary hypertension. Some of the investigations used for diagnosis of some causes of secondary hypertension are as follows. Renal parenchymal disease. First line diagnosis is by renal ultrasound. Renal artery stenosis is by renal duplex. Primary aldosteronism is by aldosterone-renin ratio. Pheochromocytoma by measurement of urinary fractionated metanephrines. Cushing syndrome by 24-hour urinary cortisol secretion. Now we come to the end of our first part of the lecture. The rest will be continued later. Thank you.